Hello everyone, this is Dr. Sultan of the Pain Shop Academy. I've completed my MD radio diagnosis from CGS Medical College and KEM Hospital in Mumbai. I'm a gold medalist, and today we are going to discuss an interesting topic, which is of fetal ultrasound. So, a subpart of first trimester fetal ultrasound, in which today we will be discussing on the USG signs of early pregnancy. So, without any delay, let us start. So, before we start, let us begin with the very basics of the topic. So here you're able to see this is uterus. I'm pointing towards the fundus of uterus. This is the fallopian tube of the uterus. This is isthmus and this is ovary. Very basics. So first thing which happens is the formation of the follicle. So you've got growing follicle. So initially you've got primary follicle, then the secondary follicle. This follicle matures to form Graafian follicle. After the Graafian follicle ruptures with the help of LH surge, the ovum is released. This ovum is caught up, and at the same time, when the sperms enter through the fallopian tube, the fertilization occurs. Fertilization occurs within the fallopian tube, zygote is formed. Now, initially, the zygote, once it forms, it starts dividing. It starts dividing into smaller cells. These cells are called blastomers. The process is called blastulation. And you see that initially there is 2 cell stage, then there is 4 cell stage, then there is 8 cell stage. And finally you have a morula like structure which is formed. This is called morula. There is no cavity. Point to be noted, inside morula there is no cavity. And after morula, you have a structure in which a central eccentric cavity forms. And this is called blastocyst. Point to be noted, implantation occurs inside the uterus in blastocyst stage. So with these basics in our mind, we'll move ahead. Okay, this is how the development occurs from zygote till blastocyst, and implantation occurs at blastocyst stage. In this session, we'll be discussing the basic considerations. We'll also discuss the indications, the basic technique, the anatomy, and the ultrasound appearances. And we will discuss the various signs of pregnancy, early pregnancy. Now, before we start, what is conceptus period? So I've already explained the development begins with the formation of zygote. This zygote divides into multiple blastomeres we saw, and then it forms a morula, then a blastula, then ultimately a cavity forms inside. So here you can see in this image, this is the blastocyst which has come up for implantation. And this cavity inside the blastocyst is called blastocele. And you can see that there is a bunch of cells over here. This is called embryoblast or the inner cell mass. These cells form the embryo proper. And you can see the flattened cells which are there in the periphery. They are called trophoblast. So the trophoblast cells, they lie in the periphery. Okay, they help in the formation of chorionic villi, and later on, the 2 types of chorion will be formed. Okay, so here you see, as this implantation has already taken place, you can see that this is the embryonic disc. This is the bilaminar embryonic disc. And you can see that there are 2 cavities inside. This is the amniotic sac, and you can see there is one cavity here. This is the yolk. So it forms an 8-like structure. Okay, it forms an 8-like structure with embryo in the center and amniotic sac above, yolk sac below. Okay, this is an important thing. You need to know this basics so that you can correlate them with the ultrasound findings. One important point: optimal condition for implantation for the endometrium is at least 7 mm of endometrial thickness. So if 7 endometrium has to be minimum 7 mm thick so that the implantation occurs. When we come to first trimester ultrasound, let us see a few basic definitions. So initial 12 weeks of pregnancy are considered to be the first trimester. So if you divide, the initial phase is the conceptus phase, which is usually 3 to 5 weeks. Here, basically, it is 2 weeks after the LMP, and the gestational sac initially it is very small to be located or to be seen by ultrasound. So those 3 weeks are considered. So that totaling gives us around 5 weeks. So from 5 week onwards, we start seeing the GSAC on ultrasound by a transvaginal scan. We'll be discussing that. So initial 6 to 10 weeks forms your embryonic phase, and later 10 to 12 weeks after that, that becomes the fetal phase. What are the indications of first trimester ultrasound? So initially, patient might present with amenorrhea. She might not know if she is pregnant. UPT can turn out to be positive. So first thing is to diagnose pregnancy. She might present with pelvic pain, vaginal bleeding, unknown menstrual dates, subjective feeling of pregnancy. Uterus can be greater or smaller than the dates of on clinical evaluation. UPT can be positive. Increased HSG values may be there, and nuchal translucency measurement. These are the first trimester ultrasound indications. If you want to summarize, most important is first trimester scan is the dating scan. You have to confirm whether the female is pregnant. So it is a confirmation scan. It is a dating scan. And most importantly, you have to confirm if the pregnancy is intrauterine or not. So you have to rule out ectopics in first scan. Let us see very basic considerations. So which probe are we going to use? So here I have shown this is the transabdominal convex probe. This is the linear probe. So normally if you are examining transabdominally, then you are going to use the convex probe. Linear probe is generally not used, but sometimes in some patient, when you're not able to see structures clearly through the abdomen and you want to a better resolution, in that case you can try using a linear probe. Very important, there is a marker on the linear probe. This is called orientation marker. It is also called eye of the probe. So we need to locate the eye of the probe because that helps in identifying the side on which we are seeing. So based on that, so if the eye is on the right side, it means that the patient's right is actually the right on the screen. So eye of the probe is again very important when you are doing any intervention, whether you're going like amniocentesis and all. So whether you're going from the eye side or from the non-eye side. Now, usually in first trimester, the best results are achieved using transvaginal probe. So here I have shown you the image of transvaginal probe. This is the transvaginal probe, and you can see that this is the marker. This is the marker. So if this is the transvaginal probe, the marker is to be placed vertically. So marker has to be facing upwards, and this is inserted inside the vagina. But very important, when we are doing the transvaginal examination, we have to take the consent of female and mentioning her the entire procedure. If a male sonologist is doing the procedure, it is very important that a female attendant is present during the procedure. So transvaginal sonography has multiple advantages over routine transabdominal sonography. So TVS is advantageous because it has better image resolution. It avoids the problem of over-distended bladder. It can be used for retroverted uterus, and it helps in the diagnosis of fetal viability early. So we'll see that as compared to transabdominal scan, transvaginal scan can detect pregnancy early. So all changes of pregnancy, be it yolk sac, be it the cardiac activity, be it the CRL, be it the fetal pole, all this are seen earlier. They are caught up early on transvaginal scan. Very useful for obese patient and very useful, very important in cases of transvaginal scan. You can see further details like chorionic bleed. So all those things can be seen very nicely using transvaginal sonography. Fetal cardiac activity can be better located. So now this is how transvaginal sono is done. You can see the patient lying down, okay, and this is the TVS probe which is inserted into the vagina. And point to be noted, look, the eyes facing upward. So when the eye face upwards, you will be getting a longitudinal scan. So the eye is facing upwards. And so the scan which you achieve will be the longitudinal cuts. So if you see longitudinal cuts, the uterus will be like this. Uterus will be like this. Okay, and this region is the cervix. So you see, this is cervix. This is the body of uterus. This region is the fundus of uterus. And this inside, what you see, this layer, this is the endometrial layer. The endometrial layer. Okay? So we can view the endometrial thickness in a better way. That is ET. ET can be viewed in a better manner. Now, very important, whenever you are doing a transvaginal sonography, patient's bladder has to be empty. You cannot put a full bladder. Patient's bladder has to be empty. That is must. So you have to ask the patient to empty the bladder. Very important. Then the probe is to be inserted. The eye is faced upwards, and then you get this longitudinal section of the uterus. Now this organ which lie behind, this is rectum. This is rectum. Correct. Now whenever you want a transverse view, you have to rotate the probe to 90 degree. So once you rotate the probe to 90 degree, you will get transverse section of the uterus. Okay, I'll go ahead now. So this is how you have to hold the probe. So the eye is facing upwards. This is my thumb which is placed over here, and this is how the probe is to be inserted. Okay, after asking the patient to void bladder. Now we'll discuss the anatomy features on ultrasound. So now you can see this image here is transabdominal ultrasound. This is TAS, transabdominal ultrasound. So on this, can you see this organ? This organ which you are able to see. This, yeah, this organ what you are able to see, entire thing. This. This is completely anechoic. What do you mean by echogenicity on ultrasound? It is how bright that organ appears on ultrasound. So you can see that this is completely anechoic organ. This is nothing but urinary bladder. This is the urinary bladder. Okay. Now this is urinary bladder. Now just look behind this. Look behind this. So we can see this organ. This organ. This organ which is just behind, posterior to the urinary bladder. This is the uterus. This is the uterus. Okay. And look carefully. Can you see this? This thing. This layer in the center of uterus. Now, if you see more carefully, you'll be able to see this thing. So this is the endometrial lining or ET. Okay. Now this portion is the cervix. This is the cervix. And this is the vagina. This is the vagina. Okay. So you can see this is uterus, the cervix, the vagina. Okay. So this is transabdominal scan. Now, similarly, if you know transabdominal scan, transvaginal scan also becomes easy. Now you see the longitudinal section over here on TVS scan. Okay. Point to be noted. This is anterior. This is posterior. Okay. Now you see, look, the bladder. It should have been here. Bladder is empty. Because in transvaginal scan, we ask the patient to void the bladder. So here bladder is empty. Now look at this organ. This entire organ. This is the uterus. Now look here carefully. This one. This is the endometrial lining. And look at the center, echogenic rim. So this is the anterior endometrium, and this is the posterior endometrium. Okay, anterior and posterior endometrium. This portion is the cervix here. This is the cervix. Okay, so this is the basic anatomy on ultrasound TVS imaging. Again, I showed the same thing. You can see this is the transvaginal scan. This is the urinary bladder, which is minimally distended. And then you can see this is the uterus, piriform organ. And you can see this region is the fundus. This is the body of uterus. This region is the cervix. And you can see this entire thing. This is the ET. So when you are going to measure ET, you have to measure from here to here using proper caliper. This is the anterior lining of the endometrium. This is the posterior lining of the endometrium. Now look carefully, this region, this behind the uterus, anterior to the rectum. This is called pouch of Douglas. Okay, pouch of Douglas. Now we are going to see the same anatomy in transverse section. So look here, this is the bladder. So that the bladder lies anteriorly. So this is the urinary bladder, transabdominal scan. Bladder is full. This is the bladder, urinary bladder. Now look behind this organ. This is the uterus. Can you see this in the center? This is the endometrial lining, ET. And behind lies the rectum. Okay, rectum lies behind this. Now look at this. This is transvaginal scan. Transvaginal scan. The bladder is here, which is collapsed. The bladder is collapsed anteriorly, and this entire thing, this entire structure, what you're able to see, this is the uterus. This is uterus. And look in center carefully. This thing. This is the endometrial lining. This is the endometrial lining. Okay. So you're able to see the endometrial lining. So this is the transverse section. Now we move ahead. So what are the disadvantages of TVS? The depth of penetration is less. That is one. The cost factor relatively, and very important that it is relatively invasive. Some females might find it uh, difficult, or some females find it awkward for this thing. But usually, if you explain them the importance of transvaginal scan, they usually agree to it. Okay. So now we will discuss the what things to be looked on in first trimester of pregnancy. One is you have to confirm the pregnancy. Second, you have to confirm whether the pregnancy is intrauterine or not. So you have to rule out ectopic pregnancy. So here we are going to discuss early features of intrauterine pregnancy. So most among important signs are the decidual sign, intradecidual sign, the double decidual sign, the double BLEB sign, the diamond ring sign, which we are going to see. Now, as soon as the patient comes to you, the most important thing is LMP, because that is an important part which helps you to date the pregnancy, and it also helps us to calculate the EDD. But suppose the patient doesn't know the LMP, or the menstrual cycle is not regular, or the previous cycles are not 28 days, or the patient was on OC pills, or patient has bled in early pregnancy, or the patient was on lactating, and in between she got pregnant. So in such cases, you cannot rely on LMP. Over there again, your early ultrasound, that is the first trimester, the earliest ultrasound becomes an important determinant of the fetal gestational age. And this first trimester scan is not only important to find out whether the female is pregnant, but it is also important to date and provide EDD. And this EDD and this date will be used further when subsequently patient will come to you in second trimester or third trimester. Again, for ultrasound, we'll be using this for follow-ups to monitor the fetal growth. Now, this slide I've added just to give you an idea. Like, this is transvaginal scan, this is transabdominal scan. If you see in transvaginal scan, gestational sac can be detected much earlier, around early four weeks. But in case of transabdominal scan, it is detected 1 week later. So it takes time. Similarly, fetal pole yolk sac can be detected on TVS scan by 5 weeks. Whereas on transabdominal scan, the same thing is detected by 6 to 7 weeks. Fetal cardiac activity can be detected as early as 5 weeks on transvaginal scan, whereas the same thing takes 7 to 8 weeks, at least 7 weeks. Sometimes with better resolution, patient is thin. You can identify even by 6 weeks. So transabdominal scan, it is agreed that it takes more time as compared to that of the transvaginal scan. The main reason behind this is that in transvaginal scan, you are directly looking at the organ of interest. As a result, the resolution is very good, and that is why you are able to diagnose things early. Similarly, similarly, placenta and ventricles are better seen in early gestation or transvaginal scan. Now look at this. Now this image, this is a scan which is done using a transabdominal probe, and this is the scan which was done on TVS, the same patient. So in this, we can hardly look at the GSAC. We can hardly see if the GSAC is present. But look over here in this scan, can you see this structure? Yeah, you can see. So this is uterus, the uterus, and we are able to see a GSAC-like structure, right? So this is how we are able to locate it early. Now, first sign which we'll be discussing, the first sign of pregnancy, which is called intradecidual sign, which was described by Ye, very old 1988. Now, this term refers to an echogenic area representing the implanted blastocyst, which is embedded in thickened decidua and is eccentrically located on one side of the uterine cavity. Now, out of this, two words are very important. Number one, it's an echogenic area. Number two, it is eccentrically located. Eccentrically located. Why this is important? See, sometimes in cases of ectopic pregnancy, you might have fluid which is trapped between the two layers of the endometrium. So that is endometrial fluid. And sometimes you might mistake that for GSAC. So how to differentiate whether that is true GSAC versus false GSAC? So remember, when the implantation occurs, the GSAC is eccentrically located. The word eccentric is very important. This is what we have to see on ultrasound. So now let us see this. So now this is a transvaginal scan. You see, this is the urinary bladder, which is empty. This is bladder which is empty. Now look at this. This is uterus. This is anteverted uterus. Uterus is anteverted. Now look at this thing. This inside is the endometrium. Now see how endometrium has thickened. So this is called decidual reaction. Endometrium gets thickened. This is called decidual reaction. Now you see this is the central echogenic rim, which separates the anterior and posterior endometrium. Now look at this. This is the GSAC. Now GSAC is eccentric. So it is more towards the anterior side than towards the posterior. It is totally embedded in the anterior endometrium. So this is what I meant by eccentric location of G-sac. This is very, very important. This is cervix. You should look whether the cervix is closed or not. Okay. And this is cul-de-sac, that is pouch of Douglas. Again, this is very important site in cases of ectopics. You should look if there is any fluid in this region, that is in the region of pouch of Douglas. Now, again, look this carefully. This is your endometrium. This is endometrium. And this is the central echogenic rim which separates the anterior from posterior. And you're able to see that this is a G-sac. And this G-sac is eccentric. That is completely buried in endometrium on one side. It cannot be. So anything which appears here like this cannot be a G-sac. It is just a fluid. Now G-sac. So again, a very important sign of pregnancy is G-sac. It is first visualized around 4.5 to 5 weeks. By transvaginal scan, even earlier you can see it by 4.5 weeks. At least by 5 weeks you are able to see the G-sac. By transabdominal scan, it takes plus 1 week. So G-sac is an anechoic space we already saw, and it is surrounded by tropoplastic tissue. And visualization of G-sac is one of the important signs of pregnancy. It is the first structure to be seen. So first you see G-sac, then you start seeing yolks, okay, and then you start seeing fetal pole. So this is the order. First you see G-sac, then you see yolk sac, and then you see the fetal pole. This is how the order goes on. Now let us see this image. So in this, can you see this structure? This is the G-sac. Now whenever you are seeing G-sac, are you able to see yolk sac? No, there is no yolk sac. Are you able to see fetal pole? No, you are not able to see fetal pole. So this is a case of early gestation, where you are still not able to see the fetal pole or anything else. So you are just able to see this yolk sac. So you are just able to see this G-sac. And so you have to take three measurements. 1, 2, and then you have to move the probe perpendicular to this. And you have to take one more measurement. So you have to measure AP, trans, craniocaudal, CC. So anterior-posterior, transverse, and craniocaudal. All three diameters you have to take, and you have to take a mean of this. Mean. So you have to add all of this and divide it by 3. So A plus B plus C divided by 3. That will give you the MSD, which is called mean sac diameter. And based on this, you determine the gestational age based on mean sac diameter. Let us move ahead. So now, before starting the next sign, you should know this. So then the things will become easier to describe the next sign. So when the gestation goes ahead, blastocyst is formed. Blastocyst implants inside the endometrium. The endometrium, the lining of endometrium is called decidua. It's called decidua. Now there are three types of decidua. The one which is here in the basal region, the one which is here, this is called decidua basalis. Decidua basalis. The one which is over here in this region, which is lining the G-sac, the one which is lining the G-sac. This is called decidua capsularis, as it forms a capsule-like structure surrounding the G-sac. So the one which is here is called decidua basalis. The one which is here is decidua capsularis, and the remaining this layer. This is called decidua vera, also called decidua parietalis. So it means that there are two decidual layers. One is this and one is this. Okay, and this is the eccentric G-sac which is embedded on one side. Okay, so this is called double decidual sign. We'll see this. So it is described as two concentric echogenic ring of tissue which surrounds the intrauterine G-sac. So we have already seen that two sac they represents, one is deciduum capsularis and one is deciduum parietalis. Okay. Now let us see this image. So again, let us see first the illustration. The one which is present here, this is the G-sac. This is G-sac. Okay. And this is decidua basalis. This layer which is surrounding the G-sac, this is decidua capsula, and this layer which is in the periphery, this is called decidua parietalis. So this is one decidua which is decidua parietalis, and this is second decidua which is called decidua capsularis, and this sign is called double decidual sign. Okay, now let us see the same thing on ultrasound. Now you are able to see this is bladder, this is urinary bladder. Now this is the G-sac, this is G-sac, and can you see this echogenic layer around the decidua? This is called decidua capsularis. And look at this, there is one more layer here. This is decidua parietalis. So this is called double decidual sign. Now here again I want to emphasize how will you differentiate true G-sac versus pseudo G-sac. So look at this image. This is uterus. This entire organ is the uterus. Now look, here you are able to see anechoic structure, but it is trapped in between two layers of the endometrium. It is not eccentric. Now again similarly see this. It is trapped in the center, and the shape is not round. The shape is oblong. So when the shape is not round, it is trapped in the center. It is not eccentric. It is pseudo-sac. But now look this. Now look at this. This is eccentric, and it is surrounded by decidua. See, this is one decidua, and this is another decidua. So when you have two decidua surrounding G-sac, this is double decidual sign. So double decidual sign again helps you to differentiate true sac from pseudo sac. Now again the same thing here. You can see this fluid here. This is not circular. This is not a round. G-sac is a round structure. So this is pseudo sac. This is not a true sac. So this is how we differentiate true sac from false sac. So whenever you have such type of appearance, pseudo gestational sac, you should always look for ectopic pregnancy. Now yolk sac. So after G-sac, we saw various signs related to G-sac. Now the second most important structure, or the first anatomical structure which is seen inside the G-sac, is the yolk sac. The function of yolk sac is to provide nutrients. It serves as the site of initial hematopoiesis. And as the pregnancy advances, the yolk sac progressively increases from 5th to at the end of 10th gestational week, with 5 to 10 weeks. And then the yolk sac gradually disappears and is often undetectable after 14 to 20 weeks. Now look at this. This is your implanted blastocyst, which then this is the embryonic plate, and you can see here this is the amniotic sac, and this sac what we are able to see is the yolk sac. Initially there is primary yolk sac which is lined by cuboidal epithelium, and then it gets converted into secondary yolk sac which is bit smaller in size as compared to that of primary yolk sac. Development of the gut, that is the entire GI system, occurs outside, and yolk sac is connected to the fetus by a duct which is called vitalo-intestinal duct. So now this is the image. Can you see this? So this is the G-sac, and we can see within G-sac a structure which is very circle, anechoic. and has a circular margin. This is nothing but yolk sac. Now you should see number of yolk sac. Number of yolk sac determines the immunogenicity, especially to rule out twin pregnancies. The first confirmatory sign that it's an intrauterine gestation and not a pseudo fluid or anything else, or not just a fluid or what we are saying, so is the presence of yolk sac. Okay, now it appears as a anechoic thick walled structure. The yolk sac should always be visualized at MSD of 20 mm by transabdominal scan or MSD of 8 mm by transvaginal scan. So that those are the cutoffs. If MSD is 20 mm, you should be able to see the yolk sac. Now look at this. Again, this is the G sac, and in G sac, this structure, this is yolk sac. Look again how beautiful this is. The G sac, the yolk sac. You're also able to see the fetal pole here. Now, the upper normal yolk sac diameter between 5 to 10 week age is 5.6 mm. It should not be calcified. Yolk sac should not be calcified or misshapen. Yolk sac which is larger than 6 mm are usually indicative of abnormal pregnancy. Yolk sac less than 2 mm at 8 to 12 weeks are associated with poor outcome. In addition, number of yolk sac I already told you is useful for determining the immunogenicity of pregnancy. So now look at this. This here you are able to see two yolk sacs. So two yolk sac, it means that this is diamniotic pregnancy. Next we are going to discuss an important sign which is called double BLEB sign. So again, this is very important. This is the earliest evidence of an embryo. Now look here. This is the embryonic plate. Above embryonic plate, you've got amniotic sac. Below that, you've got a yolk sac. So this gives a figure of 8 like structure. Okay, this is also called double BLEB sign. Double BLEB sign. So importance of two bubbles, and it is very important because once you see this, it is one of the very important confirmatory sign of pregnancy. Look here. So you're able to see the embryonic plate here. This is your yolk sac and amniotic sac. Double BLEB. So now after double BLEB sign, the most important is the presence of fetal pole. Fetal pole. So fetal pole is seen as thickening on the margin of yolk sac during early pregnancy. So here, are you able to see this thickening over here? This is the fetal pole, and this appearance is just like a ring. So it is called diamond engagement ring sign. Okay. Now look here. This is the fetal pole, and this is the yolk sac. So now you have to measure this from here to here. Whenever you are able to see fetal pole, you should give the measurement of the CRL. What is CRL? Ground rump length. So again, look here. This is the G sac. This is yolk sac, and you're able to see this structure here. This is nothing but the fetal pole. So whenever you're able to see the fetal pole, you have to give measurement from crown to the rump. So this is crown. This is rump. You have to give crown rump length. Now fetal viability. Now just seeing fetus does not confirm that it is viable. For fetal viability, most important, you have to look for cardiac activity. If cardiac activity is present within the fetus, it means that this is viable. First cardiac activity is seen around 6 to 6.5 weeks. Very important. If CRL measures 7 mm, this is the cutoff. If CRL is 7 mm, you should see the cardiac activity in the fetus. Now, we'll also discuss about this CRL measuring 7 mm and cardiac activity in fetal viability section. Now, let us see this image. This is a fetus. Now this is M mode. M mode. So M mode detects the motion. So are you able to see these undulations? These undulations detect the cardiac activity. So early in pregnancy, when in the early phase of pregnancy, we do not use color, very important, and we try to avoid Doppler. What we use is M mode. So we place the M mode cursor over the cardiac region and we look for this undulation. This is a bit relatively larger fetus. So here you are able to see undulations very clearly, and the distance between two peak will give you the fetal heart rate. Similarly, in this case, you see that this is the fetal pole. I'll show you. This is the fetal pole. So in the region of cardiac activity, we have placed this cursor. This is the M mode cursor. And now, are you able to see this undulation? These undulations, what you get. Okay. And then you have to take distance between two peaks or two troughs and you get the heart rate. So this is how you calculate the fetal heart rate. Now I'll take you through images. Now we are about to reach end of this session and I'll take you through images so that you understand better how we'll go along this. So initially 5 to 6 weeks. Look, this is transabdominal scan. You're hardly able to see just GSAC. This is transvaginal scan. You can see GSAC. Very important. You're able to see tropoplastic the residual reaction surrounding the GSAC. Yeah. Now look, after GSAC, there is development of the yolk sac. This is vitalointestinal duct. This is amniotic sac. This is called double BLEB sign. Look carefully. Now this is yolk sac. This is embryo. This is called diamond engagement ring sign. Now look here carefully. We are able to see this is Doppler spectrum. Okay, and this is the fetal pole. By 6 to 7 weeks, you can see the cardiac activity, and even earlier, 5 to 6 weeks, by TVS scan. Now look here. This is fetal pole. This is yolk sac. This is G sac. So by 7 to 8 weeks, again it develops further. Now you can see again clearly in this case, this is the fetal pole. This is fetal pole. This is yolk sac. And this echogenic, this is all the chorionic reaction. Okay, so they have got chorionic levee, chorionic frondosum, the chorion which get from that and the deciduum. So that will form an echogenic rim. Now here, after you cross certain age, like you cross 7 weeks, you can apply a bit of Doppler. That should not be applied for more time, and you should maintain a low thermal and low mechanical index, and you are able to see cardiac activity within the fetus on color. Again here we are able to see this is the fetal pole. We are nicely able to see. Okay, and we are able to see limb buds too. These are the limb buds, and you can see the palate, the mandible. This is the head region. So this is called the crown. This is called the rump. Measuring from here to here at 9 weeks will give us the crown rump length. This will just tell that the female is pregnant. But to know viability, you should see the cardiac activity. Or even on 2D, you can see the cardiac activity, and Doppler and spectrum will further add to confirmation. Now look at this. This is around 10 weeks when you are able to see the fetal head, the nasal portion, the nasal tip. You are able to see the lips. You are able to see spine. This is the entire the fetus, and this is the rump. This is the head. So you are able to see almost the entire fetus. Now look here. Why I have given this image? Now we have already seen few of the images, right? Here you can see the head very nicely. Look here carefully. Can you see make out a difference? The entire cranial vault is absent. So this is a case of anencephaly. Anencephaly. Why is this important? Because sometimes patient might come for a viability scan, and our duty is not just to look for whether the fetus is viable or not, but at the same time we should always keep our minds and eyes open and try to look whether the fetus is anomalous or not. And anencephaly is one such anomaly which is picked up very early at around 11 weeks. At around 11 weeks. In fact, it is the first CNS anomaly that can be picked up at around 11 weeks. So you need to carefully screen for such important findings. They should not be missed. Summarizing, so early signs of pregnancy includes double decidual sign, intradecidual sign, double BLEB sign. After you see G-sac comes the yolk sac. The fetal pole is the last to come, and then the cardiac activity. When CRL measures 7 mm, cardiac activity should be seen. Fetal cardiac activity is most important to label the pregnancy as viable.